Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the deep dive. Today we're taking a really crucial look at something that touches every single one of you on the front lines. Whether you're in the operating theater, on the wards, maybe running clinics across the NHS. We're talking surgical safety and incident reporting, specifically in general surgery. We've pulled apart a recent really insightful guide on this.
Okay.
Our mission, well, it's to distill the most important, actionable nuggets of knowledge for you to help you navigate risk management, clinical governance, and, quality improvement effectively in your day-to-day.
And what's truly fascinating here, particularly for you working doctors and surgeons, is how these systems, like Datix,
Right.
they're not just about ticking boxes for compliance. They're actually powerful tools. They can help sculpt a much safer environment. And that's not just for patients, it's for practitioners too.
That's a great point.
So we'll offer you practical insights into those common incidents you might see, try to demystify the reporting process a bit, and look at some crucial strategies for prevention.
Absolutely. You're going to get a clearer picture, hopefully, of the specific incidents that should be triggering a Datix report.
Yeah.
We'll touch on the subtle, sometimes not so subtle challenges that can, unfortunately hinder effective reporting. And critically, how you can personally contribute to building a culture of continuous improvement, turning individual incidents into system-wide learning. Okay, let's unpack this then. Understanding the landscape first. Common incidents in NHS general surgery.
Right.
Our source makes it really clear. Grasping these common things, their causes, the reporting mechanisms, it's just foundational for anyone in this field. So let's break them down by category and see what they actually mean for you in practice.
Sounds good.
First up, intraoperative complications. Stuff that happens during the surgery itself.
Okay.
Leaving the list. Bleeding or hemorrhage. It's, surprisingly common, actually. Affects maybe 5 to 10% of major surgeries.
That's quite high.
It is.
Yeah.
But here's the key insight. It's not just any bleeding. Datix reports often reveal it's the uncontrolled bleeding, often stemming from maybe subtle vessel injuries or perhaps unrecognized coagulopathies, even technical slip-ups.
Yeah.
That's what forces a patient back to theater.
Right. Leading to longer stays, more risks.
Exactly. It's that secondary intervention that really highlights the severity in the report.
Yeah, and that's precisely where the systemic learning kicks in, isn't it? It's not just, bleeding happened.
No.
It's, why did this specific bleed need a re-op? What could have been different, technically or systemically, to prevent that escalation? That's the critical question Datix helps answer.
Exactly. Well put. Then there's bowel or organ injury. A classic example the guide points to is iatrogenic bowel perforation during a lap cool.
Keyhole gallbladder removal, yeah.
Right. While it's relatively rare, maybe 0.3 to 0.5% of cases, the implication is huge. It's a direct Datix trigger because it so often leads to this cascade. Prolonged hospital stays, significant risk of sepsis, and sometimes, devastatingly, potential litigation. It's one of those moments where a seemingly small misstep can just unravel the whole care pathway.
It really can.
And here's where the data gets, really sobering. Wrong site surgery.
Oh, yes.
Thankfully, incredibly rare, maybe 1 in 100,000 procedures, but when it happens, it's just catastrophic. For the patient, obviously, but it's also this fundamental breach of trust.
Absolutely, a system failure.
A stark indicator of deep systemic failures. Now, the WHO surgical safety checklist is our absolute frontline defense. We know that. But our source emphasizes these incidents often expose more than just someone missing a tick box. They frequently stem from these subtle breakdowns, don't they? Team communication issues.
Lordy gradients.
Yes, or just a lack of psychological safety, that feeling you can't speak up, even when the checklist looks like it's being followed. It's about the spirit of the checklist, not just ticking the boxes.
Precisely. That lifeline isn't just about checking boxes, is it? It's the critical thinking, the unwavering culture of speaking up that the checklist should be fostering in everyone.
From junior to senior.
Exactly. From the most junior person to the lead surgeon. When wrong site surgery happens, the how often points to a really chilling breakdown in that shared responsibility.
Okay, moving on then to post-operative complications, what happens after the procedure.
Right.
Surgical site infections, SSIs. They're a persistent challenge. You see them in maybe 5 to 20% of cases. even higher in colorectal surgery.
Yeah, colorectal is particularly high risk.
And what's often maybe overlooked is that NHS Datix data consistently points to SSIs as a leading cause of 30-day readmissions.
That's huge.
It is. This isn't just a clinical outcome metric. It's a significant burden on beds, on staff time, and it directly impacts hospital performance for every single trust.
And think about it from the surgeon's perspective. A readmission for an SSI isn't just about the patient's discomfort, which is bad enough.
Of course.
It's about potential further intervention, the psychological impact on the patient, and frankly, the strain on your team and resources. It really underscores why every single step of infection control,
Pre-op prep, wound dressing.
all of it becomes this high-stakes endeavor, every single time.
Right. Next, deep vein thrombosis, DVT, and pulmonary embolism, PD. These pop up in about 1 to 5% of patients after major surgery. And our source highlights this recurring theme in Datix reports. These serious complications are often attributed to inadequate VTE prophylaxis.
Venous thromboembolism, yeah.
So it's not just a statistical link. It points to a critical point of failure in our preventative protocols. And the consequences can be fatal.
Absolutely critical to get that right.
And then there's anastomotic leak. This is particularly relevant and often devastating in colorectal surgery. The risk sits somewhere between 3 and 15%.
Which sounds like a range. But
Our source emphasizes how each percentage point there translates to immense patient suffering and a huge systemic burden. It's not just a number. That, say, 10% mortality rate and prolonged ICU stay represents a profound cascading impact on resources, on staff morale, on families.
it really highlights the fragility, doesn't it? Even when the surgery itself seems successful, this complication can just change everything.
Precisely. Finally, under common incidents, we have system and human factor errors. Now, these are absolutely crucial because they often highlight these broader underlying issues going beyond the individual patient.
Right, the system context.
Exactly. Medication errors are a prime example. Think wrong antibiotic dosing, maybe a missed VTE prophylaxis dose. And crucially, some medication errors, like administering the wrong drug entirely, fall under the category of NHS never events.
The name says it all, really.
It does. It's a declaration.
Yeah.
These are incidents so egregious, so fundamentally preventable, that they point to a complete breakdown in multiple safety layers when they occur.
That's such a critical distinction, host, because when a never event does happen, the focus shouldn't immediately be on blaming an individual.
No.
It should instantly trigger a deep system review. How did all our safeguards fail simultaneously for something that should simply never have happened?
Precisely. Then there's delayed diagnosis or mismanagement. A stark example from our source is a missed acute appendicitis that unfortunately perforates.
Yeah, you see that.
And Datix reports frequently link these kinds of incidents to systemic pressures, don't they? Delays in A&E, maybe misinterpreted imaging.
Which points directly to things like resource constraints or maybe training gaps that impact your ability, the team's ability, to deliver timely care.
Right, and we can't overlook equipment failures. Could be anything from an insufflator malfunction during a lap procedure
Which can abort the case or cause discomfort.
to stapler misfires, which can have immediate, really severe patient consequences. These aren't just minor glitches, they have serious implications, often leading straight to a Datix report.
So if we try and connect this all back to the bigger picture for you working doctors and surgeons, it's incredibly clear, isn't it? Understanding these categories not just as isolated events, but as potential systemic vulnerabilities, it helps us identify those common pitfalls in practice. It moves you from just reacting to incidents to hopefully proactively anticipating and maybe even preventing them. What really stands out to me is how often these categories intertwine. It's rarely just one single thing.
That's a really good point. It's often a complex web.
Yeah, a web of factors rather than one single point of failure.
Which brings us neatly to a critical tool in managing and, crucially, learning from these incidents. Datix. Let's really dive into what it is and how it functions, because for any NHS professional, it's an essential part of the job.
It really is.
So what exactly is Datix? Well, simply put, it's the NHS's centralized risk management system. It's for logging incidents, near misses, hazards.
A whole spectrum.
Exactly. It's not just about recording things down. It's incredibly versatile. It acts as the backbone for clinical governance. It's a crucial defense against litigation, and perhaps most powerfully, it enables detailed trend analysis, spotting patterns, areas for improvement right across your trust.
That trend analysis is key.
Absolutely. Now, the next crucial question for you is, when should you report? Our guide makes this very clear. You should report any instance of patient harm, an injury, an infection, sadly, even a death.
Okay.
But here's the bit that's often underestimated. You must also report near misses.
Ah, yes, the good catches.
Exactly. Our source emphasizes that a near miss, like, say, the wrong drug being prepared but thankfully caught before it was given, that's a gift of information.
It's a great way to put it.
It provides invaluable data before harm occurs. And of course, all never events like wrong site surgery require immediate Datix reporting with clear escalation pathways.
No question there.
Now, how do you actually report? Most of you are probably familiar with logging into your trust's Datix portal, but our guide highlights the critical importance of the details you put in.
It's not just a tick box exercise.
Not at all. You fill in the incident details, patient, staff involved, but crucially, you assess the severity using the harm scale, usually 1 to 5.
Right.
But more importantly, you're prompted to identify the root cause. Was it human error? Was it a system failure? A combination. The specific detail is where the real learning potential of Datix lies. Then finally, you escalate the report to your clinical governance team, making sure it gets the right review and triggers the necessary institutional response. That emphasis on root cause is so vital. For NHS staff, particularly in surgery where, let's face it, the pressure is immense.
Intense.
The immediate instinct might just be to log it quickly and move on. But taking that extra moment just to think about why something happened beyond the surface level, that's what transforms a simple log entry into actionable intelligence for the whole system.
Absolutely. However, and this is a major focus in our guide, there are some significant...
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
challenges in Datix reporting that we really need to face head on.
Yeah, the barriers.
One of the biggest is persistent underreporting, often driven by this deeply ingrained fear of blame among staff.
Understandable, but problematic.
Very, or sometimes it's simply due to the intense time constraints on the wards. In theater, there just isn't time. This fear, though, it's a cultural barrier we have to collectively try and overcome.
Mm-hmm.
There's also delayed reporting. If reports come in weeks later, it directly affects the accuracy and timeliness of trend analysis. If the data isn't fresh, it's much harder to act decisively.
You lose the momentum.
You do. And finally, inconsistent data entry. If different teams or individuals record things differently, it can really limit the usefulness of audits. Makes it difficult to spot those clear patterns and pinpoint areas for targeted improvement.
This raises such a fundamental question for all NHS staff, doesn't it?
Yeah.
How do we foster a culture that genuinely encourages reporting, despite these very real pressures and fears?
Yeah.
It's about transforming the perception. Seeing a report, even for a near miss, not as an admission of blame or culpability, but as a genuine gift of information. Every single piece of data you contribute through Datix helps build a safer system for everyone.
For patients, colleagues.
For your patients, for your colleagues, and ultimately for you too. It's a proactive step towards safety, not a punitive one.
Okay, let's zoom out a bit then. What are the broader implications of these incidents across the NHS? How do they directly affect you and your teams? Because it's not just about that immediate incident. The ripple effects are huge.
They really are.
Let's talk about never events in surgery again. Our source reiterates the most frequently reported ones, and it's a stark reminder of where our deepest vulnerabilities might lie.
Mm-hmm.
These include wrong site surgery, like doing a hernia repair on the wrong side, retained foreign object swabs, instruments left inside a patient, and misplaced nasogastric tubes causing aspiration. These aren't just unfortunate slips, they are clear markers of system failures that we absolutely have to learn from, deeply and transparently.
Agreed.
Beyond the clinical impact, there's a significant litigation and financial impact. The numbers from NHS resolution data are pretty stark. General surgery accounts for roughly 15% of all claims against the NHS.
15%, that's substantial.
It is. And the top reasons for these claims, often delayed diagnosis, think a perforated appendix missed initially, or intraoperative negligence, like a bile duct injury during a routine op. These claims carry massive financial burdens. Money that could be spent on staffing, equipment, training.
Diverted away from patient care. And it's not just about the final payouts either, is it? The process of litigation itself is incredibly taxing. For a working surgeon, that constant background threat, it weighs heavily.
Absolutely. And finally, it's so crucial we acknowledge the profound impact on surgeons and the teams. Experiencing or being involved in an incident takes a massive psychological toll.
Huge.
There's the fear of litigation, which can be crippling. It significantly contributes to burnout among healthcare professionals, affecting well-being, affecting retention. For severe cases, there can even be regulatory consequences, GMC referrals. It's a heavy weight to carry, and it's often a direct consequence of an incident not being adequately prevented or, crucially, learned from.
When you connect all that to the bigger picture, it's just undeniable. Incidents have these far-reaching consequences that go way beyond the immediate patient.
Right.
They deeply impact team morale, they drain financial resources, they can even erode public trust in the healthcare system itself. Understanding these trends isn't just academic. It's key to advocating, isn't it? For better resources, better training, better support for your teams and departments, making sure you have what you need to deliver truly safe care.
So, armed with all this knowledge, what are the actionable strategies? What does our source outline to effectively reduce incidents and truly enhance patient safety within your daily practice?
Right.
This is where the rubber meets the road.
Exactly. The what can we actually do part.
Let's start with preoperative strategies. First foremost, checklist compliance, specifically the WHO Surgical Safety Checklist. Our guide really emphasizes this isn't just a task, it's got to be a mandatory culture. And linked right into that is the timeout protocol, that critical, deliberate pause just before incision, confirming correct patient, site, procedure.
Absolutely fundamental.
Our source shows how these protocols, when they're truly embraced, aren't just about stopping wrong site surgery, they foster this collective vigilance in the team.
And what's often forgotten about the checklist and the timeout isn't just the act itself, but the opportunity they create.
How so?
They give every team member a structured moment to voice a concern, to clarify something, to contribute. They are, or should be, tools for empowering the entire surgical team, not just the surgeon.
That's a great point. Moving into the intraoperative strategies, structured training is absolutely key. Things like laparoscopic simulation training,
SimSuites, yeah.
allowing you to hone complex skills in a safe, repeatable environment. Our source highlights just how crucial these simulated scenarios are for building muscle memory, critical decision-making, all without patient risk.
Invaluable.
Also vital are team briefs for high-risk steps. For instance, before achieving the critical view in a cholecystectomy, a quick brief ensures everyone's aligned, understands the plan, knows what to look out for. These small moments of communication can significantly reduce risk.
Little pauses that make a big difference.
Exactly. After the surgery, post-operative strategies. Enhanced recovery protocols, ERAS pathways. They're increasingly important.
Definitely.
They're meticulously designed to get patients mobile, recovering faster, which we know directly reduces complications like SSIs and VTE, and crucially, morbidity and mortality M&M meetings. Our guide stresses these are not blame forums. They are indispensable meetings.
The learning engine, really.
Precisely, where incidents are openly discussed, analyzed meticulously, and most importantly, learned from. Ensuring systemic flaws get identified and hopefully prevented from happening again.
And finally, we need to look at system-level improvements. This includes leveraging digital tools, things like barcode scanning for swab counts.
Reduces retained objects.
Exactly. Greatly reduces the risk of that particular never event. But perhaps the most vital system-level improvement our source underscores is a fundamental culture change.
The blame-free reporting idea again.
Yes, that vital shift towards encouraging blame-free reporting. Actively cultivating an environment where every single member of the surgical team feels psychologically safe. Safe to report an incident, safe to report a near miss, without any fear of reprisal, knowing it will be used for collective learning, for genuine improvement. It's about seeing the data as a friend, not an enemy.
What's fascinating here, as you said before, is many of these strategies aren't brand new concepts, are they? They've been around.
Not revolutionary, no.
But it's their consistent application, embedding them into the very fabric of the culture. That's what truly makes the difference. It's about building these multiple overlapping layers of safety that protect both patients and the surgical team from, well, the inevitable human errors we all can make.
Building resilience into the system.
Exactly. Okay, let's bring this to life now with a specific, really compelling case example from the source, laparoscopic cholecystectomy complications. This really shows the full cycle, doesn't it? Incident, reporting, learning, change.
Yeah, it's a great illustration.
So the incident we're focusing on is bile duct injury. As we mentioned, it occurs in maybe 0.3% of lap cols. It's a severe complication, significant long-term consequences for the patient, massive impact on the system.
And what made this particular type of incident so powerful for learning was the consistent reporting over time. Datix wasn't just used to log that an injury happened.
No.
It was used to log the circumstances around it. That detail was captured.
Right. So when a bile duct injury occurred, the Datix report details were absolutely crucial. The reported cause, time and again, kept coming back as misidentification of anatomy during the procedure.
A clear pattern emerging from the data.
Exactly. This recurring pattern, identified through aggregated Datix data, wasn't ignored. This finding led to a very specific, actionable intervention, mandatory critical view documentation, which meant surgeons had to formally document that they had achieved the critical view of safety, clearly separating the bile duct from the cystic duct and artery before they proceeded with clipping and dividing any structures.
That's a perfect illustration, isn't it? Collective data driving tangible change. Moving beyond just looking at individual incidents to spotting a systemic vulnerability, and then implementing a focused, verifiable solution.
And the outcome. The result of this systematic approach, directly driven by those comprehensive Datix reports and the subsequent targeted actions, well, it was impressive. In some NHS trusts, this initiative led to a reduction in bile duct injuries by a remarkable 40%.
40%? That's huge.
It really is. This isn't just theory. It's a tangible patient safety win. It directly impacts lives, reduces litigation, eases the burden on surgical teams. This is the why it matters, right there in action.
Absolute powerful example.
What an incredibly insightful deep dive, I think, into surgical safety and incident reporting within the NHS. We've covered quite a lot, from those common complications you might encounter daily to the nitty-gritty of Datix reporting, the wider consequences, and most importantly, those proactive strategies you can actually implement right now.
And ultimately, I think the key takeaways for you as working doctors and surgeons are pretty clear. Firstly, report early. Report often. Even those seemingly minor and near misses.
The gifts of information.
Exactly, because every piece of data you contribute helps build a safer, more robust system for everyone involved. Secondly, learn from every incident, especially through those crucial M&M meetings. They really are your department's greatest learning opportunities. Don't shy away from them. And thirdly, continuously work to prevent recurrence. Use robust checklists. Engage in ongoing training. Make safety an ingrained habit, not just a policy you follow.
So as you go back to your shifts this week, maybe consider this provocative thought. How can you personally contribute to shifting the culture in your team or maybe your whole department? Shifting it away from one where reporting might feel like a burden or maybe even a risk to one where it's genuinely seen as an essential proactive step towards improving patient safety for everyone, for your patients, for your colleagues, and ultimately for yourself.
Food for thought.
Thank you for joining us on this deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.